you, Sarah, and really pleasure to be here. I'm gonna share my screen now. Hopefully this will work. Okay, so I'm Matt Goldenberg. I'm an associate professor and actually the clerkship director for medical students at Yale Medical School. And my colleagues will introduce themselves as we get to their portion of the talk. But today we're going to be talking about a presentation or reprising a presentation that we gave back sort of right at the beginning of the coronavirus pandemic time in Dallas, called Grabbing the Third Rail, Race and Racism in Clinical Documentation. We have nothing to disclose regarding this. And then today's agenda, so I'm going to frame the discussion. My colleague, Dr. Williams, is going to then take us through a clinical case, and I'll then finish framing the discussion. Then Dr. Isom is going to talk a bit about defining race and racism. Dr. Williams will then come back and talk about the problems with race medicine. And then Dr. Rohrbaugh will talk about how we might better conceptualize the utilization of race and racism in clinical medicine, particularly with an emphasis on structural competency. Just to be clear, the first portion is going to be didactic with some interactivity via polls. If you have questions at any point or comments, feel free to use the chat. We'll be trying to monitor that as well. So a lot has changed, obviously, in the country and in the world since we gave this presentation in March. One of the things that we anticipated before the presentation in March was that this was going to be a difficult thing for folks to think about and talk about, particularly white people who have historically, many of whom historically in this country don't see race or pretend or don't think that they see race. I think a lot has changed with after the murder of George Floyd. I think the national conversation has really taken a big shift on this, and so hopefully this will be a sort of more comfortable conversation. Still maybe challenging for a lot of us, but a conversation that people are starting to get used to having, an important one to have. All right, so maybe we can pull up the first poll. So which of the following best describes your program's teaching in terms of mentioning or recording a patient's race as identifying information? Sort of that one-liner at the beginning of an oral presentation or at the start of a note.
Would it be possible to read this off, because it's very blurry and I don't see what the choices are?
Okay, sure. So it says the top choice is residents are taught to do so as a matter of routine. Next is residents are taught to do so only if relevant in a particular case. Next is residents are taught never to mention race. Next is residents are taught to do so elsewhere in the chart or the electronic medical record. And lastly, we have no specific teaching about this issue in our program. All right. Sarah, when it looks like a critical mass has answered, we can reveal the. All right. So it looks like residents are either taught to do so routinely or not taught anything specifically at all, or the plurality of those choices. All right, great. So we're gonna move on and ask the next question, which is, when a colleague or trainee mentions race or records race in the patient's medical record, what do you do with that information? Do you usually notice? So the choices are going to be, I don't usually even notice that they've done so. Next is, I incorporate it as relevant to the patient's case. Next is, I wonder why they mentioned it, but I don't discuss it. And lastly is I use the opportunity to engage in a discussion of race and its medical relevance. Okay. Let me reveal the poll answers. All right. So pretty widespread distribution here. The plurality, almost half, say I incorporated it as relevant to the patient's case. And then there was a comment in the chat that these aren't necessarily mutually exclusive, that you could do more than, potentially more than one of these answers. All right. Well, what we're going to do now is present a case and use that case as an opportunity to talk about the issues that it brings up. And so, Dr. Williams, I'll turn it over to you.
Hey, Matt. Can you hear me?
Yes.
I can hear you, yeah?
Fantastic. Thanks for that transition. I'm so pleased that we could spend this time together today talking about an important topic. I'm going to introduce a case, the central themes of which are from a real case that I've seen, and then some parts fictionalized to protect the identity of the patient and to drive home some teaching points. So Matt, if you could transition to the next slide. So this is a 19-year-old, and as I go through the case, I'd like everyone to kind of hold this case in your mind as we present, because we're going to refer back to this case throughout the presentation. This is the case of a 19-year-old male, recent high school graduate, lives with his mother, father, and 13-year-old younger brother. No formal psychiatric history. He had seen a school counselor in the past just for some anxiety. Currently employed in a retail business stocking shelves, and the chief complaint was there's been a misunderstanding. The patient gets a 19-year-old history of asthma, hypertension, was brought into emergency department by police for quote unquote bizarre behavior and making threats towards his coworkers. And according to the police report, on the day of admission, the patient reported to his job at Walmart as per usual as a shelf stocker. He mostly keeps to himself at work, and at his lunch break, he was sitting by himself, kind of in the corner of the break room, and suddenly started shouting at his coworkers. "What are you saying? Stop talking about me. I'm going to F you up." He accused his coworkers of talking behind his back, calling him racial slurs, and he did not physically strike anyone or was not aggressive. The coworkers immediately reported his behavior to the manager, and they called the police. And when the patient learned that the police were called, he walked out of the store and down the street. And as the police approached him, he appeared to be talking to himself. Upon being stopped, the patient was irritable. He denied anything had happened. He accused the police of following him unfairly. He also claimed that his coworkers were being biased towards him and conspiring to get him fired. And police then brought him into the ER for evaluation. He arrived in the ER restless, pacing the unit, saying that there had been a misunderstanding. "I'm not supposed to be here." He was able to be redirected back to his room without the use of any restraints or medications. Upon exam, he was irritable and begrudgingly cooperated, but did cooperate eventually. He reported that his coworkers were talking about him behind his back and that he should be discharged from the emergency room. He initially denied any problems other than his coworkers' behavior and voiced some frustrations that he had been blamed for their harassment. He acknowledges that sometimes he feels sad, but said everyone is. He reports some problems falling asleep at times. And then upon getting collateral from his parents, they had not noticed any acute changes in his behavior or personality, but they noticed kind of a progressive increase in social isolation around the time of his graduation. They attributed this to him feeling more sad because some of his friends went away to college and he was a little bit more lonely. And now he plays video games in the basement more than usual. He expressed little interest in attending college, as he said that school was not his strong suit, and recently did mention that he thinks his coworkers are saying bad things about him and bullying him. In terms of just the history, again, no prior outpatient psychiatric treatments, no past history of inpatient hospitalizations, no suicide attempts, no prior medicines. He endorsed marijuana use at the age of 16, starting at the age of 16, smoking 2 marijuana cigarettes a day, saying that it relaxes him, no alcohol use, no tobacco or other illicit substances. Medical issues, hypertension, asthma, seasonal allergies, where he uses an albuterol inhaler. In terms of family history, there's depression and alcohol use on mom's side of the family. There's an uncle that lives in a group home for kind of unclear issues related to bizarre behavior and cognitive limitations. In terms of social and developmental history, no prior prenatal exposures, was born at term, some delays in speech initiation, received early childhood services. He was about an average student, had 1 or 2 good friends in school. Parents were married and generally supportive of him. Vital signs were within normal, except for a little tachycardia or mild tachycardia. And in terms of his mental status, he was young appearing as stated age, was reasonably groomed, casually dressed, untucked shirt. He was seated at his bed, looking around the room, seeming distracted, poor eye contact. His answers were terse. His speech was sparse and a little monotone. He said his mood was fine, but appeared anxious in his affect. And his thought content was mostly around feelings of being harassed and questionable paranoia. His thought process was, again, terse and concrete, but no gross disorganization. And his cognitive exam was grossly intact. And his labs were positive for the THC.
Okay, thanks, Corey. So what I'd like for you to do now is just consider the following questions. So is the patient's race relevant to this case? And if so, how? And if not, why not? Think to yourself about the answer to that question. And then the second question is whether or not you would document the patient's race in the medical record. If so, where and why? And if not, why not? Take a few moments to think on those issues. And then ask you, as a training director, someone involved in residency education, if a resident were presenting this case to you, which of the following best describes whether and why you would expect trainees to consider or document race in this case? You can pull up the next poll. So the first one is no, they should never consider a patient's race. In this case is no different. No, they should document a patient's race when relevant, but it doesn't seem to be so in this case. Next answer is yes, the patient's race could help the trainee choose the appropriate pharmacologic treatment. Next is yes, the patient's race could help the trainee understand the interaction with police. And finally, last answer is yes, the patient's race could help the trainee understand his family's perspective on mental illness. Okay. All right. So a large majority said that yes, the patient's race could help the trainee understand the interaction with police. All right. Okay, so I put these sort of after that initial case, but as good educators, I want to go over the learning objectives. So during and after this session, participants will reflect on the ways in which they utilize race in their own clinical practice and in their training programs. And then based on the next series of didactic slides, we describe the historic origins of race and make connections to contemporary significance. Understand racial health disparities as products of social inequality rather than as products of inherent biological differences between racial categories. Cite evidence of the limited utility of race in the medical chart and how race is often used to discriminate or deliver substandard care. And then articulate some specific instances, where race in the chart might actually be useful and how it might be useful. So when we include race, why do we do it? And there are a few different answers that most people will give, but one, as came up earlier in one of the earlier polls, is that that's sort of what we've been trained to do. We're accustomed to doing it. It's sort of part and parcel of the medical presentation is to mention race, just like age and gender in the one-liner, and we don't necessarily even give it that much thought. Another is, and probably related to it being a custom, is that it is assumed in many cases to have relevance. And in fact, in many cases, it's assumed to have biological relevance. It may be assumed to have some cultural relevance. And I think increasingly what we're seeing is that folks appreciate that the relevance that it actually might have is as an exposure or experience. So being of a certain racial group in a certain setting and time exposes one to racism. Another reason we might want to include race or consciously consider race is to check our own implicit bias as a opportunity for self-reflection. And then some folks are very concrete about this and talk about how it helps actually identify a person on the unit. But why might we not include race? Well, in many cases, it may not be relevant. I think some would argue that it activates, given that we are all, if we were reared in this country or have spent significant time in this country, we've lived in a racialized society, and so it might activate stereotypes or problematic heuristics mentioning race. A key element, I think, is that it perpetuates the idea that races are inherently different, often with sort of a biological rationale. And as a corollary to that, it makes consideration or proper consideration of race and racism and exposure to racism less likely. And then I think with increased patient access to their own charts, some people might worry about mislabeling. How do we know how a patient identifies, or the appearance of discrimination? So this is now a decade-old study, but of medical students. But it does show that most in many medical schools, where most medical students are taught to selectively mention race. Some of them, about 10%, routinely mention it. And about 20%, it's not actually taught, and another 10%, they're taught never to mention it. All right, I'm going to shift gears and turn it over to Dr. Isom after we watch this video.
You may think you know exactly what race you are, but how would you prove it if someone disagreed with you? The fact is, even though race drives a lot of social and political outcomes, race isn't real. One of the first people to attempt to categorize humans according to race was a German scientist around 1776. He came up with 5 different groups according to physical appearance and geographic origin of their ancestors. Americans of European descent eagerly bought into this type of thinking around the same time. Some historians have said the idea that there were different races helped them resolve the contradiction between a natural right to freedom and the fact of slavery. If whites were their own distinct category, then they could feel a lot better about denying freedom to people who they labeled black and decided were fundamentally different. But as political priorities change, definitions of race in America adjust right along with them. For example, if you were of Mexican birth or ancestry in the United States in 1929, you were considered white. Then the 1930 census changed that to non-white to limit immigration. Later, when the US needed to increase its labor force during World War II, these people were switched back to white. And what it took to be black once varied so wildly throughout the country, from 1/4 to 1/16 to the infamous 1 drop of African ancestry, that people could actually change races just by crossing state lines. Then suddenly in 2000, the government decided that Americans could be more than one race and added a multiracial category to the census. This has left many Americans scratching their heads when it comes to selecting who they are. As many as 6.2% of census respondents selected some other race in a 2010 survey. The idea that someone might look one way and identify another way, or that they might be really hard to place in a racial category, is not new. This is why there was a public debate about whether MSNBC's Karen Finney could say she was black, or how we can't even agree on the racial label assigned to the President of the United States. Of course, many people feel their racial identity is very clear and very permanent, but the fact that some people have changed theirs and that no one can really argue with them shows how shaky the very idea of race is. This is all because there isn't a race chromosome in our DNA that people can point to. It simply doesn't exist. When the medical community links race to health outcomes, it's really just using race as a substitute for other factors, such as where your ancestors came from, or the experiences of people who may have been put in the same racial group as you. Dorothy Roberts explains that sickle cell anemia is a prime example of this. The disease is linked to areas with high rates of malaria, which include some parts of Europe and Asia in addition to Africa. It's not actually about race at all. This, of course, does not mean that the concept of race isn't hugely important in our lives. The racial categories to which we're assigned can determine real-life experiences, they can drive political outcomes, and they can even make the difference between life and death. But understanding that racial categories are made up can give us an important perspective on where racism came from in the first place.
Thank you, Matthew. So we're now going to transition to our next Poll Everywhere question, and I appreciate you all bearing with me for this next section. It'll be a whirlwind for exploring some of these concepts a bit more from the video. So this question is, thinking about the case, I would consider the patient's racial identity, particularly potential minority status, in determining his genetic risk for certain disorders. The answers are strongly agree, neutral, not sure, disagree, and strongly disagree. I'm looking forward to seeing the answers. Oh, there we go. So it looks like it leans towards strongly disagree and disagree, as well as a significant third or so that's agree or neutral, not sure. All right. So on the next slide, I wanted to make the point here that race is a messy topic to unravel. And I think it's meant to be messy because that makes it more aversive. I put here some comments from the Vox video, which you can review later when you have the slides, that illustrate the diversity of experiences of watching the video and subsequent thoughts on what the video introduces as a topic. Some people reject it, some people accept it, some people are wholly confused after watching the video. Next slide. Just reiterating the concepts here, but really focusing on what changed over time and how we categorize people. So it's important to start with understanding, and this is a great quote from Ta-Nehisi Coates' book, Between the World and Me, that race is the child of racism and not the father. So categorizations of peoples evolved over time, and in the Middle Ages and previously, things like religion and language were identifiers for groups of people, and these were components of ethnicity. And there were really no physical identifiers. Over time, race as a word began to be used and was put in the same grouping as words like type, kind, breed, or even species. As peoples increasingly interacted across different land masses, there needed to be a way of describing those who were from the continent of Africa versus the indigenous peoples and the Europeans in the early colonial settler communities. And race was increasingly ascribed to those groups. And ultimately, written use of race increased, which propagated its association with the racial hierarchy. It was really important for this evolution that race be a static thing, whereas with ethnicity, previously, you could move from one part of a landmass to another and adopt cultural practices, adopt languages, adopt religions, and change your ethnicity. It was important for race to be static. Once you were given a race in the socio-political understanding, which we'll get to in just a moment, that was your race. Next slide. So Dorothy Roberts wrote a key text for diving deeper into this. It's called Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century. I put here a key quote from her text, and she says, and I quote, "Who qualifies as white, black, and Indian has been the matter of countless rule changes and judicial decisions. These racial reclassifications did not occur in response to scientific advances in human biology, but actually in response to socio-political imperatives. And what they reveal is that being defined, organized, and interpreted is a political relationship and not an innate classification." This was referenced in the Vox video as well. And to your left on the screen, you see a census, which just, if you look at those over time, you've seen how many categories have expanded for what people can select. Next slide. So understanding the evolution of race and how it's related to racism requires a historical lens. So I put this here just to make the point that race in documentation has always been associated with racism since the beginning of time. So we're waking up to a certain extent in certain spaces with certain groups of people about this phenomenon, but in medicine, it's an association that's always been there. And the alarm bell of what that means for the care that we provide for patients has been snoozed on for some time. And hopefully this is an impetus for no longer selecting that button. So I encourage you to access resources like Stamped from the Beginning by Ibram X. Kendi to really appreciate the history of race, particularly in the United States. Next slide. So scientific racism is often referred to as a thing of the past. Here you see an image on the left that details intelligence quotient, IQ, for the world. And somehow the lowest IQs are concentrated in the landmass of Africa, and the highest IQs are concentrated in European landmasses. This is just one example of how the IQ test is rooted in scientific racism, but often not interrogated through that historical lens. On the right is a really excellent book that details the history of the spirometer. Back in chattel slavery days, when physicians were interacting with enslaved persons, they created this imaginary difference, racial difference in lung function. That has been propagated over time and has now been packaged into spirometers. So there's a black button for spirometers. And it just shows how a racial difference detailed in scientifically racist practices is actually woven into what we still do today, which is correcting for race when we're measuring lung volumes. Next slide. This is another text called Black and Blue, History of Medical Racism. It's by John Hoberman. He's a medical historian. I'm not going to read this slide for you or the next one, but I did want to show you the breakdown of how the book essentially outlines racial differences in the history of medicine that continue to have present day relevance. The point that he makes as an author is that these racial mythologies or racial folklore beliefs are still present in how we regard patients. So there are racial differences outlined in JAMA, all of the different primary texts that we've been accessing for the past couple of centuries about hearts, teeth, eyes, lungs, ability to participate in psychotherapy, a number of different things. So I'd encourage you to read this chart, but also the book to get a better appreciation for that history. Next slide. Here is another way of adding an historical lens to how we think about the development of our discipline, psychiatry as well as psychology. So here you can see the chattel slavery alongside the development of our disciplines, and increasing interactions of people across the world reinforced each other. So psychiatry and psychology contributed to scientific racism by offering a pseudoscience that supported racial difference. And racial difference always is referencing a racial hierarchy where whites are superior and blacks are inferior. So when looking at the present day manifestations of that, we might think about our screening tools, we might think about how we characterize a good patient versus a bad patient, and things of that nature. And this book will help make the point that we also have to interrogate our present day practices with an historical lens as well. Next slide. So this is a newly written piece by Vanessa Grubbs, who's a nephrologist, that speaks to a lot of the advocacy and activism around GFR reporting in the labs. If you Google this, you'll find lots of articles out there that reference medical students actually working with nephrologists to remove corrective GFRs from lab reports because it's essentially rooted in scientific racism. And this chart on the right just details how that racial science, again, has been propagated over time and included in the corrective GFR equations that we use today. Next slide. This is a 68-page report that was released, I think, within the last month by the Institute for Healing and Justice in Medicine, also a collaboration between medical students and faculty. This is one of the groups that spearheaded removing corrective GFR from their lab institution at a facility, I think, in California. So I also encourage you to access this website and download this free report to get a better understanding of the biological underpinnings of some of the decisions that we make in medicine. Next slide. This is also a new piece in the New England Journal of Medicine, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. They detail different algorithms across a number of specialties that correct for race and what the equity implications of that correction factor might be. Interestingly enough, psychiatry is not included in this paper. I think that's a paper waiting to be written, but there is a lot in here from pulmonology, radiology, gynecology, and all of these other specialties. Next slide. The meaning of race has changed over time, and one of the papers that you can read to better appreciate why race is still relevant is this paper, How Race Becomes Biology, Embodiment of Social Inequality. Again, referencing the quote from before, we embody social inequality and it has biological consequences. So in any discussion of racial disparities, we need to make the connection between those two things. Next slide. Just to reinforce the point again, race does not equal genes, but on the next slide, this might be a novel way of considering that. When we think about differences between people, we often assume racial difference. So if I appear white, if I appear black, there must be a large percentage of that difference that's rooted in our genetics. The image on the right shows that the diversity within the continent of Africa is actually more diverse than between a member of an African country and a person from America, for example. So if you were to select the genetic material from a person from Ethiopia or Sudan and compare it, there would be more genetic diversity between those two people who both appear to be black than there would be from the person from Sudan and someone from Texas. Next slide. Still another layer to add to this is that self-identified race is when you ask a person how they identify, but it might be less relevant than socially assigned race. Socially assigned race is where we decide by looking at an individual what racial category they belong to. If I were to move to Brazil, I might be considered white in that particular area because they have different racial categorization processes there. However, here in America, I am black. If I identified with lighter skin as black, but others saw me as white, all of those things would track with my health outcomes. So these are 3 papers that show that socially assigned race actually is one of the things that we should be thinking about when we're examining how race is associated with health outcomes. Next slide. Thank you.
So I think Dr. Williams is going to take it from here.
Sure. Already going back to the case of the 19-year-old young man, if the patient is identified as a racial minority, he is likely to receive differential treatment. Would you strongly agree with that statement? Agree? neutral or don't know, disagree, or strongly disagree. Okay, it looks like a little less than half agree. Some strongly agree, others aren't sure, and a small minority disagree. And in thinking about this case, would you say that you worry that documenting or considering race in the identifying information might activate negative stereotypes or false beliefs about the patient? Strongly agree, agree, neutral, don't know, disagree, strongly disagree. Okay, looks like more than half agree. Another good portion of people strongly agrees. Few folks are not sure. Okay, so I'm gonna pivot a little bit in my section to ground us again in the significance of the medical documentation. And I think that the challenge is that it's difficult to tease out what are the specific contributions or implications of the chart. Because what we're really talking about is one piece of a larger encounter with race in a medical encounter, which would include factors like the patient's physical appearance, how the patient's appearance is named in the chart, for example, the physician's own racial identity, the physician's own racial biases, so on and so forth. All these factors are going on. But I think for the scope of this presentation, I think what we want to argue is that the current practices around identifying race, particularly uncritically, adds a significant contribution to the disparities that we see in the ways in which minoritized communities are differentially treated. And we argue that when the physician sees a racial minority named in the chart, this activates certain negative judgments and stereotypes, or can activate negative judgments and stereotypes that fundamentally changes diagnostic thinking and treatment decisions. And so with the next handful of slides, my goal is going to be, number one, to convince you of that the physician learning of the patient's race, either through documentation or through seeing a sort of phenotypically Black or minority, fundamentally changes diagnostic and treatment decisions, either consciously or unconsciously. But at the same time, how race is identified in the chart is presents an opportunity for the physician to actually know and learn about the patient's race. And that has deleterious effects on the patient's care, including medical education, diagnostic and treatment decisions, and medical and so on and so forth. So I'm gonna move to the next slide and give you a sort of famous example. This is Dorothy Roberts, who's at UPenn in the African American Studies department. She did an interview on NPR where she talks about a famous case where the diagnosis was missed. So we're going to play a quick audio clip.
Okay, so where has this led us? I mean, like, what are some of the modern consequences of making assumptions and making a diagnosis using race?
Well, one example that comes out of the medical literature is the true case of a little African-American girl who had persistent respiratory problems. And you can look at her file and see 2-year-old African American girl, back in emergency room for respiratory problems. 4-year-old African American girl with another pneumonia. And then when she was 8 years old, a radiologist looked at the x-ray of her chest without knowing her race and said, "Who's the kid with cystic fibrosis?" Now, if she had been white, the doctors would have diagnosed her right away, as a baby, maybe, as having cystic fibrosis and treated accordingly.
And is that because, statistically speaking, white people are much more likely to have cystic fibrosis?
Yes, that's true. So because she was black, they assumed she couldn't have cystic fibrosis, even though she had the symptoms of cystic fibrosis.
Okay, so that's an example of how, a direct example of how this medical error was in part due to the fact that the patient's race was documented. In the radiologist activated certain beliefs about, racialized biological implications. And the radiologist in this case did not associate African American with cystic fibrosis. And you could argue that had this patient's race not been documented, then the diagnosis would have been made much sooner to the benefit of the patient. Next slide. This is a famous historical example. It was one of the first published cases of sickle cell disease in Egypt, and published in a prominent medical journal. Now, the authors of this case report felt that it was important enough to identify this patient as a, quote, white girl, and even show her picture, because they wanted to emphasize that this patient did not have any, quote, Negro features, as quoted in the case, and the patient did not have ancestry known to be Negro. And these authors failed to realize that all of those imports that came with documenting white race in this girl's chart, and this is a patient who was hospitalized several times and really had a chronic course of sickle cell disease before someone thought to actually run the test for sickle cell and make the appropriate diagnosis. And as you can see from the quotes that I've featured here, that through the racial identifications in the chart, they're really creating and reinforcing these racial meanings. And what these authors did not understand is that being socially assigned as a quote Negro is not a biological or genetic category, that it's a social category. And this patient, again, could have been diagnosed much sooner and gotten much better care if race wasn't so foregrounded in her chart and in her care. Next slide. And as a quick aside, to just drive home the point, is that sickle cell is one of the main ways in which people justify thinking about inherent biological difference between the racial groups. And contrary to this popular misconception, sickle cell is not a Black disease. Sickle cell is a disorder that affects millions of people across every ethnicity, including in South America, Cuba, Central America, Saudi Arabia, India, Turkey, Greece. And yes, U.S. whites also get sickle cell disease, but it's often misdiagnosed as a related blood disease. And it's been misconstrued historically as a Black disease, and the implication has been sort of an inferior Black biology. But as one scholar, Harriet Washington, wrote, almost anywhere malaria is found that's the common denominator of sickle cell disease, not race. So sickle cell is really a disease of the malaria mosquito, not a racial disease. Next slide. This is a interesting study that at least makes the case that race as documented changes the conversation in a clinical presentation on rounds. This is a study at Hopkins by author Finucane et al. And what they did here was the chief medical resident recorded whether, how often, and where race was used in a daily clinical presentation and rounds over a 2-month period. And they recorded whether or not, as quoted in the paper, there was unflattering characteristics were attributed to the patient. So that would be things like illiteracy or low intelligence, uncooperativeness, anger, violence, criminal record, or unemployment. And they recorded whether or not those adjectives or descriptors was also associated with the patient's race. And what they found was race was much more often prominently featured and repeatedly featured in the presentations of Black patients. And among patients who were ascribed as unflattering characteristics on rounds, race was much more likely to be specified for Blacks than for whites. And, you know, I think what this study suggests is that, you know, the white patients were disproportionately sort of unmarked in their racial identity, and it was sort of seen as a normal that if you don't mention race, you sort of assume that it's a white patient, and if it's a Black patient, you should feature that prominently as a sort of a significant note, whether biologically or socially or whatever. And so again, this idea that how patients are identified in the chart continues to construct and create racial categories and meanings that we have associated with racial groups. Next slide. This is data looking at patient-physician communication, where they use audio tape and questionnaires to determine whether the quality of a medical visit communication differed between African-American patients and white patients who visited over 60 physicians in the Baltimore, Washington, and Northern Virginia area. And the encounters were independently coded for a communication process, patient-centeredness, emotional tone of the medical visit. And what they found was that patients were spending less time with their Black patients, had less positive affect during those encounters, and were much more verbally dominant with the African-American patients. Next slide. This study has a really important implications, I think, for medical education. This study performed by Hoffman and colleagues at University of Virginia Medical School suggests that race in medical education makes a significant difference to students and residents' beliefs about race. So self-identified white medical students and residents were given a survey about a variety of false beliefs about racial differences. And what they found was that in many of these questions, the majority of white students and residents endorsed these beliefs, such as Blacks had thicker skin than whites, or that Blacks had higher thresholds for pain than whites, or that whites had larger brains. This is not a study from the 18th century or 19th century. This is modern medical students and residents believing all of these false biological beliefs. And I'm going to make the case in the next slide, Matt, you can go ahead, that this actually matters to how patients are treated. So what happened next is that they had the medical students and residents read two mock cases, identical cases, one from a Black patient and one about a white patient, and they were asked to rate the patient's pain on a 1 to 10 pain scale, and then make medical recommendations to treat the patient's pain. And those white medical students and residents who endorsed more false beliefs rated the Black patient's pain as less severe or lower, and made less accurate treatment recommendations, suggesting that the false beliefs between Black and whites did inform medical judgments, and definitely contributed to the racial disparities in the pain assessment and treatment for these particular students and residents. And again, it's unclear sort of, what, did the students and residents come into their medical training with those beliefs, or did they get taught those beliefs either explicitly or implicitly during their medical training? So that's a significant question from the study, but it definitely suggests that students and residents are learning racist ideas about false biology at some point during their training, and they're responding to the racial identity of patients. Next slide. This study looking at working with cardiologists was kind of a similar study where they used computerized surveys and vignettes where they had standardized patients present a case or present symptoms, and the cardiologists were asked to assess whether their pain was coronary in nature and whether or not they were likely to prescribe thrombolytic therapy, or essentially to treat the underlying coronary disease. Next slide. And despite the same scripted vignettes, identical pain descriptions, and identical lab data, changing the race of the patient in the clinical vignette mattered as an independent factor. So they found that race and sex of the patient affected the physician's decisions about whether or not to refer the patients for chest pain for cardiac catheterization. And after variables were adjusted for symptoms, the physician's estimates of the probability of coronary disease, the findings were most striking for Black women specifically, as they were the group to least likely be recommended for thrombolytic therapy. Next slide. And this is actually reflected in our national trends. To say, just give a brief note that this was a retrospective registry study looking back in 2004, looking at how we see this underestimation of Black pain and Black symptoms in the national trends. So the door to balloon times, essentially the time when a patient presents to when they get to the cath lab, or door to drug times when they get their medication, that time is much longer for Black and Hispanic patients, significantly longer for Black and Hispanic patients as compared to white patients. So we see that race is important, to say the least, for diagnostic and treatment decisions. Next slide. And I want to mention this quote because this is a psychiatrist, Dr. Sattel, who writes in an op-ed in the New York Times that she does explicitly note the patient's race. And she says that stereotyping often works. And when I prescribe Prozac, for example, for a patient who's African-American, I start with a lower dose, 5 to 10 milligrams instead of 10 to 20 milligram dose. And this is despite the fact that there's no evidence for racial differences in pharmacodynamics or pharmacokinetics. And as we've been discussing, self-identified race is not a proxy for genome or the patient's pharmacogenetic profile. So we have people who are consciously making race-based decisions. And then this is also reflected in national trend data where Black and Hispanic patients are receiving antidepressants at much less lower rates than white patients, even after controlling for sex, age, family income, self-perceived mental income, and insurance status. Next slide. And there's also biases in prescription practices. There's evidence that shows that racial minorities are prescribed disproportionately older antipsychotics such as Haldol and Thorazine, less likely to receive second-generation antipsychotics such as risperidone and clozapine. And our minoritized communities are much more likely to receive depot injections in some instances. And again, difficult to tease out what are the contributions around the documentation, how race is identified in someone's medical chart, but that certainly suggests that there's a significant impact there with how physicians and prescribers think about race and how they learn about the patient's race. Next slide. And I'll just end on this note, which is a sort of psychiatric paper. It's been well known for several years that African-American patients are overrepresented in state and inpatient facilities, particularly under involuntary conditions. And this, of course, is a culmination of factors in terms of delays in care, access to care, and also interactions with law enforcement, for example. The overrepresentation of African-American patients held in involuntary conditions certainly suggests that encounters with race influences level of care decisions in psychiatry. Next slide. So I'm going to end my section here with this poll. So in considering that information, what's the most useful place to identify a patient's race in the medical chart? And I'll read those. Demographic information, such as in registration, identifying information, or the HPI, social history, mental status exam, formulation, or nowhere. Well, it looks like a pretty even spread with a few folks saying mental status exam. So I'm going to turn it over to Dr. Rohrbaugh.
Hi, everyone. It's great to be with you this afternoon. We've heard a lot so far in the presentation about adverse outcomes that are associated with race. I'm going to try and talk about some positive outcomes that might occur if we consider race, especially in the formulation. One place is certainly in research. We've heard a lot about underrepresentation of minoritized communities in research, particularly in access and dissemination research. We've talked about the social history as being able to improve understanding of someone's experiences as they move through society. And so I'd like to talk a little bit about developing a cultural and structural formulation. Next slide. So I'm certain that everyone's teaching the cultural formulation interview, and it was based on this idea of cultural humility, that you really don't know anything about the person sitting in front of you, and so you need to ask. Next slide. And so the cultural formulation domains are the patient's definition of their disorder, the cause of the disorder, their own cultural identity, and then their interactions with individuals from in the past and interactions with their current treaters. Next slide. So I think the cultural formulation is a really important part of why race might matter. But we also know that people live in communities with social determinants, including environmental, financial, healthcare access, housing, and the rest are pretty familiar to us from medical school. Probably the first one is not so familiar in terms of thinking about discrimination or bias as a social determinant, but it certainly is part of what contributes to the adverse impact that social determinants can have, or the positive impact that social determinants can have on white communities. Next slide. And if we think about these social determinants and their effect on health of communities and individuals living in those communities, we spend 4 years of medical school and another 4 years of residency talking about how to provide good clinical care. But if you look at the effect that clinical care has on the health of communities and the individuals in those communities, it's only about 20% of the health of the variance is because of clinical care. So we spend an awful lot of time talking about that and neglect issues like social determinants, health behaviors, and physical environment. Next slide. And so in 2014, Jonathan Metzl and Helena Hansen came out with this idea of structural competency. Really important paper that tries to bring these social determinants into the office. And I'm just going to briefly review these 5 core competencies or sub-competencies. Recognizing these structures, so recognizing the social determinants, developing an extra clinical language by infusing this language into case formulations. So So thinking about these social determinants when we're thinking about case formulations, re-articulating cultural formulations with structural language. So for example, they give an example of a Black patient who comes in with hypertension who's been unable to change their diet. A cultural formulation might be that high fat, high salt foods are part of the culture of African American patients. But if you ask more questions, you might find out that the community where that patient lives is only served by bodegas or corner stores for food. And so the only food that's available is high fat and high salt processed food in those stores. So it's this idea of thinking whether cultural versus or structural is really the appropriate way to formulate a situation. And then to create structural interventions, including advocating for change. So this is really an activist orientation towards physicians having some degree of responsibility for that 40% of health that's contributed to by the social determinants. And then last is structural humility, understanding that these structures took hundreds of years to be put into place, and that while we're going to advocate for change, we need to realize that it's going to take some time to make those changes. Next slide. So how might we begin to bring those social determinants into the office? And so the Philippe Bourgeois Structural Vulnerability Assessment Tool is one way to teach that to our residents. It goes over issues like food access, financial security, social network, legal status, education, and actually provides some examples of the questions that you might use. And importantly, next slide. It includes questions about bias and discrimination. So a question like, have you experienced discrimination based on your skin color, your accent, or where you're from? These are things that at least I understand that I'm of the older generation, but these are not questions that I learned to ask, and I don't think that a lot of people in the younger generations have as well. And then finally, ask yourself silently, oh, could I go back to the last slide? Might some service providers, including me, find it difficult to work with this patient based on their interactional style or essentially implicit bias? And so we've taught our residents to think a lot about countertransference based on activities that happened to them early in their life with authority figures, essentially. But I think we also need to be thinking about these kinds of implicit biases that can work in the same way as countertransference might, but are even potentially more unconscious. Next slide. So certainly race impacts our providers. I think we need to teach our residents to know their vulnerabilities using something like the implicit association test to be able to monitor when they're working with a patient who's different than they are, how they might be neglecting to provide access to resources. Our residents are amazing gatekeepers for resources. We need to be able to help them begin to talk about race and racism. Again, we presented this before George Floyd. It seems like everyone's talking now about white fragility, but I think it ought to be something that certainly we as educators read, and probably our residents and especially our white residents should also know about. We need to be thinking about advocacy to address these social determinants and dismantling white supremacy. And again, I'd really recommend that everyone read the Kendi book. It is amazing the ways in which white people have created explanations for their racist ideas. Next slide. Race certainly impacts our patients as well. Their empathic connection with their clinician trust, and hopefully developing better outcomes over through the development of cultural and structural understanding. Now I'm going Next slide. I'll return it back to Corey.
Thanks, Dr. Warbaugh. And I want to kind of, we're going to round off the presentation here with just giving a few examples. And I don't, can we go back? I don't want to present this as a sort of perfect example or an exemplar, but just an example of how you might do this. So given that we've established that race is a social category, not a genetic or biological category, if race is to be used in the chart, what we argue is that the best place to do it could be the social history or the structural formulation as an opportunity to contextualize the patient's racialized experience. So you might say something to the effect of, the patient identifies as African American and recently has felt racially targeted at his place of employment. He reports that having been called racial slurs on multiple occasions, most of his colleagues are white and he feels that they exclude him from social activities. In addition, the patient reports that he's recently pulled over by the police and subject to a random search. So this gives you a little bit more context for his racial experience and puts it in a context where it emphasizes the social and political implications. And another quick note is that, we also recommend that self-identified race be collected in demographic sections of the medical charts so that information can continue to be collected and we can continue to do this important research about health disparities. Go ahead.
Okay, so we're going to send you to breakout groups now. And within your breakout room, discuss the following questions. So based on this and with the latest information from the social history that Dr. Williams just described, what would be your formulation of this case? What structural elements might you consider and how would you incorporate data about the patient's race into your formulation? So we'll go into breakout groups for about 5 to 7 minutes and then call you back.
Hello. I hope that was interesting for folks and got an opportunity to talk through some things that maybe you were thinking about throughout the presentation. And feel free to use chat function if you want to share some thoughts or comments or reflections from your breakout room. But we're going to transition into a kind of example. So we asked you to reflect on a kind of formulation for this patient that might be helpful in terms of thinking about his racial experience. And so here's an example. So of maybe an element or a few sentences you might say. So the patient describes his symptoms as stemming from his experiences of racial discrimination at his place of employment and from law enforcement. Experiences of racial discrimination is a risk factor for a variety of mental health outcomes. And as many of these communities had been historically targeted by law enforcement, his recent interaction with the police prior to admission may have triggered a highly anxious and agitated state, which might be seen as a reasonable non-pathological response. And while admitted, feelings of anxiety were exacerbated by armed hospital security who patrolled the unit. So you can see here the themes of how his experience is much more contextualized in a structural formulation this way, and how this might actually change your diagnostic impression and your treatment decision. Going from, was this patient prodromal? Was he having overt psychotic symptoms to, was this a sort of appropriate response given his racial experiences and given prior traumatic experiences? And that might help you to guide your clinical decision making in a very real and concrete way. So we're going to transition. We'd like to have another brief breakout room to give people the opportunity to reflect on how you'd incorporate this content into your programs or the educational environments that you're in. So what we've talked about, around identifying patients' race and documentation, what are best practices around that, what resources may be helpful to you, and what barriers do you imagine encountering?
Thank you very much for your participation. Wanted to open it up now to reflections about how you would bring this content back to your program, or any resources or barriers that you see, and any questions that you have for the group as a whole. You're welcome to use the chat or unmute yourself and ask the group as a whole.
So, hi, I'm Ashley. So thank you guys so much. This has been great. And our group was talking about how we really want to share this with both our faculty and our residents. And, I think for me, these sorts of things, the biggest barrier is always time, and just finding where am I going to fit this into already, booked up curriculum and things like that. This is what I've said on other things, that you just got to use the platforms that are available to you, right? Like if you're in charge of curriculum, you're in charge of curriculum. If you're in charge of faculty development, you're in charge of that. If you're in charge of psychotherapy training and formulations, slot it in there, right? Find the place that you can and make it, and the key there is also not just putting it into didactics, but working it into the clinical settings as well. And starting young, like I was saying that I teach I am clinically with the interns, and like I started just this first month and saying like, we're not going to put, race in the identification, and they just did it, and it's fine. I was like, oh, this was easier than I thought. We'll just start when you're an intern, and in 4 years, everybody will be doing this, and it'll be great. So, thanks.
Yeah, I think that's an excellent point. And I mean, both early as well as with the idea that it doesn't get undermined by some hidden curriculum, so that it's not sort of siloed in the didactic series, but then undermined in their clinical sites with sort of this uncritical use of race in that one-liner.
Yeah, just following up with that, it's one thing to teach the residents, it's another thing to teach the faculty. And I think one of the problems that we've had is that we've done a lot of work with the residents, but we've not done sufficient work with the faculty, and so they don't see it modeled in their clinical sites. And so I would urge you to think about the faculty as well as the residents. I'm now having to go back and try to, with the assistance of my colleagues, to try and retrain people on this. Because they're not seeing it modeled.
There's some comments in the chat here. And just reinforcing the concept that working on ourselves as role models is really important. I echo that. And I put in the chat to answer the question from Dr. Hall, like, is there a right answer? The goal was for this to be a critical consciousness exercise, so to actually interrogate how we make use of race in our documentation, often putting it beside age and sex as if it has biological relevance. So our goal was to produce that consciousness, to critique where we place it, but we actually recommend as a group that it's placed in the social formulation and or the structural formulation, because that offers an opportunity to properly contextualize it. So if you're kind of disoriented and confused and not quite sure where to land, that's what we have to offer you. But a part of this was very experiential and trying to figure out how to think about this. So.
Thank you, that's really helpful.
Dr. Williams, did you want to discuss your initiative?
Yeah, I appreciate everyone's attention and time today. I just want to give a quick plug. And a few of us are trying to, really create an organization for social justice educators that are really trying to do this work and create some high quality curriculum and high quality content for social justice issues. And so I'm gonna throw a link into the chat for just a quick Google form if you're interested. And what we want to do is kind of create a space where we can learn from one another and collaborate together on how to do this really well. And we want to also support people at their home institutions for this kind of work by offering a variety of things like case conferences and workshops and that are going to be open to the community, webinars, newsletters, and we're going to do some great web development. So I'm really excited about this initiative. And if folks want some more information, feel free to fill out that form. It's a 30-second form, and we'll be in contact with you.
Mhm. And on the next slide, me and Corey also co-authored an action paper for the APA in 2018 that has now been finally produced as a CME for free on the psychiatry.org website. You don't have to be a member to access this. It's completely free, so members of the public can access it as well. So we encourage you to also disseminate this widely, because this is, I think, the first production from an organized medicine group that explicitly talks about this topic. So we hope that that's useful as well.
Great. Well, I'm not able to see the chat, so I'm not sure if there's anything else there that merits mention to the whole group.
Well,
If not-
Corey, it looks like for your link, there might have been an error message for Elizabeth. And then referencing the video from the APA, it is a little bit weird to access because they haven't quite publicized it, but I can send a link to it to Sarah, and she can disseminate that to AdPERT.
Yeah, we can email the resources out to everyone.
Well, thank you all again for joining us. It's been a real pleasure, and we look forward to working with you all on these initiatives moving forward. And please, our emails will also be available on the AdPERT website along with the recording of this presentation. So feel free to be in touch with us for future collaboration or with any questions or further comment. Thank you very much.
Okay, thank you.
Thank you.
Bye.
This was great.
All right, all. I will get it posted on Monday. So if you just want to forward the updated PowerPoint to me and any other materials, I will have it on the website.
Great. Thanks, Sarah.
Thank you all for your time. I really appreciate your hard work. You did a great job.
Thanks.
Yeah, great job.